Okay, so today we're diving into a topic that's, well, it's pretty weighty, but also really important. We're talking about cervical cancer. And I think right off the bat, there's this statistic that really kind of hits home. Back in 2018, there were over 13,000 new cases of invasive cervical cancer diagnosed just in the U.S. alone.
Yeah, that's a big number, and unfortunately over 4,000 of those cases resulted in death.
It's heavy stuff. But here's the thing, and this is what I find so fascinating about this topic. Over the last 40 years, we've actually seen a huge drop in deaths from cervical cancer, like something like a 50% decrease.
Exactly, and that really speaks to the power of early detection and the amazing advancements in treatment options that have come about in recent decades. I mean,
Yeah.
it's a real testament to how far we've come in understanding and managing this disease.
Totally. And that's what we're really going to dig into today. We want to go beyond just, throwing numbers around and really get into the why. Why does cervical cancer happen? And more importantly, how can we stop it from happening in the first place?
Right, because knowledge is power, right? The more we understand about this, the more control we have over our own health.
Exactly. And a good place to start, I think, is with the location. Where does cervical cancer usually begin?
Well, it often starts in a particular area of the cervix called the transformation zone.
Transformation zone. Okay. That sounds kind of, I don't know, mysterious. What's going on in this zone?
Well, think of it as this kind of meeting point. It's where two different types of cells on the cervix come together, the squamous cells and the columnar epithelial cells.
Ah, okay. And it's this dynamic area where like cells are constantly changing and that's where these, I guess you could call them bad seeds, these cellular changes that can lead to cancer are most likely to start popping up.
Exactly. And now we got to ask, what's the main culprit behind these changes? What's like the big bad wolf in this story?
Well, in most cases, the finger points to a persistent infection with something called HPV or human papillomavirus.
Right. And it's important to note that HPV isn't just one single virus. It's actually a whole family of viruses. But there are some real troublemakers in this family that are linked to cervical cancer.
Yeah, we're talking about the high-risk strains. And, when we look at the stats, two types really stand out. HPV 16 and 18, those two are responsible for a whopping 70% of cervical cancer cases.
That's a huge percentage. I mean, it's clear they play a major role. But,
Mhm.
just to be thorough, there are other high-risk types too, like 31, 33, and 45. It's not just those two, but they're definitely the heavy hitters.
Right. So we know these high-risk HPV types are the main bad guys, but how exactly do they get there? How is HPV transmitted?
Well, it's spread through direct skin-to-skin contact, specifically in the genital area.
And it's incredibly common. I mean, think about it. At least 50% of sexually active people will come into contact with some type of HPV in their lifetime. It's just that prevalent.
Yeah, it's something a lot of people will encounter at some point. But here's the crucial point. In most cases, your body actually fights off the virus on its own. Your immune system steps up, does its thing, and you're good to go.
Right, no harm, no foul. But, and this is a big but, sometimes the infection doesn't clear up, it sticks around, and that's when things can get a bit dicey.
So let's talk about the nitty-gritty, the how. How does a lingering HPV infection actually lead to the development of cancer?
Okay, so this is where we got zoom in, like way in to the cellular level. The high-risk HPV types, they have these things called oncogenes. Think of them like little genetic troublemakers.
Troublemakers, huh?
Yeah.
What exactly are they up to in there? What are they messing with?
Well, there are two main ones we need to talk about, E6 and E7. E6, this one, it goes after a protein called P53. Now, P53, it's like the guardian of the cell. It keeps things in check. If there's any damage to the cell's DNA, P53 steps in, tries to fix it, and if it can't be fixed, it tells the cell, hey, time to self-destruct. Apoptosis, they call it. It's like a built-in safety mechanism.
Right, so P53 is like the quality control manager, making sure everything's running smoothly.
Exactly. But when E6 comes along, it basically disables P53. It's like taking the quality control manager out of commission. And without that oversight, things can start to go haywire.
Oh, I see. And what about E7, the other troublemaker? What's its target?
E7, it sets its sights on another protein called the retinoblastoma protein, or ARB for short. Now, ARB, it's like the brakes on the cell cycle. It prevents cells from dividing uncontrollably.
So RB keeps the cell division in check, make sure it doesn't go overboard.
Exactly. But E7 comes along, messes with RB, and essentially releases those brakes. So now the cells are dividing like crazy without any of the usual restrictions.
So with E6 and E7 working together, it's like a double whammy, right? They create this environment where cells are growing unchecked, and there's no apoptosis to get rid of the abnormal ones.
Exactly. And that leads to what's called dysplasia. It's basically the development of abnormal cells. They start looking different, behaving different, and if left unchecked, dysplasia can eventually progress to full-blown cancer.
And to track the severity of these changes, doctors use a system called CIN, right? Cervical intraepithelial neoplasia. It's like a grading system for how abnormal the cells are.
Right. So you have CINI, which is mild dysplasia. It's the least severe, and often these changes just go away on their own. Then there's CIN2, which is moderate, and CIN3, which is severe dysplasia. These higher grades, they're more likely to stick around or even progress to cancer if they're not addressed.
So the CIN system helps doctors determine the level of risk and figure out the best course of action.
Right. It guides decisions about whether to just monitor the situation, do more tests, or intervene with treatment to prevent things from getting worse.
Okay, so we've got a good understanding of how HPV can trigger these changes in the cervix and how those changes are classified. But HPV isn't the only piece of the puzzle. There are other things that can make a person more vulnerable to developing cervical cancer.
Right. There's a whole bunch of risk factors that can come into play, like starting sexual activity at an early age and having multiple partners. That just increases the chances of being exposed to HPV in the first place.
And of course, smoking always seems to rear its ugly head when we talk about cancer. What's the link between smoking and cervical cancer?
Well, for starters, smoking weakens your immune system, so your body's less equipped to fight off those HPV infections. And the chemicals in cigarette smoke, they can directly damage the cells in the cervix, making them more susceptible to the effects of HPV. It's like a double whammy.
The sources we've looked at also talk about the role of other infections, like co-infections with things like HIV, HSV2, and chlamydia.
Yeah, having those other infections can make it harder for your body to clear HPV, and that can increase the risk of cervical cancer developing down the line, especially HIV, because it really knocks down your immune defenses.
It's interesting, they also mentioned long-term use of oral contraceptives as a potential risk factor. Do you know much about that?
Well, it's still being studied, but some research suggests that taking the pill for a long time might be linked to a slightly higher risk of cervical cancer. But, you got to weigh that against the many benefits of oral contraceptives, and it's something to discuss with your doctor.
Right, it's all about balancing those risks and benefits. Now, there's also mention of diet, specifically a low intake of fruits and vegetables. How does that factor in?
Well, a healthy diet is crucial for a strong immune system. So if you're not getting enough of those essential nutrients, your body might not be able to fight off infections as effectively, and that could make you more vulnerable to HPV and its consequences.
And any kind of immunosuppression, like what you might experience after an organ transplant, is also a risk factor.
Yeah, absolutely. If your immune system is compromised for any reason, you're more at risk of those persistent HPV infections and all the complications that come with them.
The information also mentions something called DES exposure. Can you explain what that is?
Yeah, DES stands for diethylstilbestrol. It was the synthetic estrogen that was given to some pregnant women way back in the 40s through the 70s. They thought it would prevent miscarriages, but turns out it caused some serious problems for the babies exposed to it in the womb.
Right. It was later linked to a bunch of health issues,
hmm
including a higher risk of certain cancers, including a rare type of cervical cancer.
Exactly. And lastly, they mentioned family history. It seems like having a close relative with cervical cancer might also increase your risk.
So there could be a genetic component, but it seems like HPV infection is still the main driver.
Right. Genetics might make some people more susceptible to HPV or to the progression of those precancerous lesions, but the virus itself is still the primary culprit. The information also talks about potential disparities in screening. Specifically, it mentions that women who have sex with women might be underscreened for cervical cancer.
Yeah, and that's a real concern because anyone with the cervix is at risk of HPV and cervical cancer regardless of their sexual orientation.
Right. So it's not just about who you're having sex with, it's about having a cervix.
Exactly. And there's sometimes this misconception that women who have sex with women aren't at risk, and that can lead to less frequent screening, which means precancerous changes might go undetected for longer.
And that could lead to later stage diagnoses, right, when the cancer might be harder to treat.
Exactly. So it's super important for everyone to be aware of their risk and to talk to their healthcare providers about the appropriate screening schedule.
Mhm.
We need better education and more equitable access to screening for everyone.
Absolutely. Now, let's switch gears a bit and talk about one of the biggest weapons we have in the fight against cervical cancer, the HPV vaccine.
Oh yeah, the HPV vaccine. This is a game changer, a true success story in preventative medicine. Can you tell us more about it? How does it work and how effective is it?
So the current version is called Gardasil 9, and it's awesome because it protects against 9 different types of HPV. And guess what? Those 9 types include the ones responsible for 90% of cervical cancers.
That's incredible. So it's targeting those high-risk types we talked about earlier.
Exactly. And when given at the right time, it can reduce the risk of cervical cancer by up to 97%. That's huge.
So when is the best time to get vaccinated?
Ideally, before someone becomes sexually active, the recommended age range is between 9 and 26. The idea is to get protected before any potential exposure to HPV.
And that makes sense. But what about people older than 26? Is there any benefit for them?
Yeah, actually, Gardasil 9 has been approved for use in adults up to age 45. So even if you've already been exposed to some HPV types, the vaccine can still protect you against others that you haven't encountered.
Oh, that's good to know. And the information mentions another vaccine, Cervarix. How does that one compare?
Cervarix is great too. It protects against HPV 16 and 18, which, as we said, are the big ones. But Gardasil 9 offers broader protection by covering more high-risk types, plus the ones that cause genital warts.
So it's a wider safety net.
Exactly. But, and this is crucial, even if you're vaccinated, you still need regular screening.
Right, the vaccine doesn't cover every single HPV type out there.
Exactly. So let's talk about screening. How do we catch those precancerous changes early on?
Well, the main tools are the Pap smear, also known as a Pap test, and the HPV test.
So the Pap smear, it looks for any abnormal cells on the cervix. And
Yep.
the HPV test, that one specifically checks for the presence of those high-risk HPV types.
And you can do them together, which is called co-testing, or separately.
And the guidelines say that screening should start at age 25. The preferred method is HPV testing every 5 years. But if that's not available, then co-testing every 5 years is also good. Or, if HPV testing isn't an option, then a Pap test every 3 years is the way to go.
So different options depending on what's available. But starting at 25, that's the key takeaway.
Yeah, but remember, these are just general guidelines. It's always best to talk to your healthcare provider about what's right for you because individual circumstances can vary.
Absolutely. Now, what happens if a Pap smear comes back abnormal? What are some of the things they might find?
Well, there are a bunch of possible results. One common one is ASCUS, which stands for atypical squamous cells of undetermined significance. That often just clears up on its own. Then there's ASCH, LGSIL, which stands for low-grade squamous intraepithelial lesion, and HGSIL, which is high-grade squamous intraepithelial lesion.
So a range of findings from less serious to more concerning.
Right. And if there's anything abnormal, the next step is usually a colposcopy. It's basically a closer look at the cervix using a magnifying instrument.
Ah, so they can see things in more detail.
Yep, and if they see anything suspicious during the colposcopy, they can take a biopsy, a little tissue sample, to examine under a microscope.
And those LGS and HGSEL results, they tie back to the CIN system we talked about.
Yeah, exactly. LGSIL often means CINI, which is mild dysplasia, and HGSI usually means CIN2 or 3, the more severe dysplasia.
And for those higher grade lesions, they often use a procedure called LEAP.
LEAP, that stands for Loop Electrosurgical Excision Procedure. It sounds fancy, but it's actually a pretty straightforward outpatient procedure. They use this thin wire loop with an electrical current to remove the abnormal tissue.
So it's both diagnostic, because they can examine the tissue, and therapeutic, because it removes the bad cells.
Exactly. It's a very effective way to prevent those precancerous cells from progressing to cancer.
Now, let's shift our focus to cervical cancer itself. What are some early signs that someone might have it?
Well, that's the tricky part. In the early stages, cervical cancer often doesn't have any noticeable symptoms. That's why regular screening is so crucial to catch those changes before they start causing problems.
So it's a silent threat in the beginning.
Unfortunately, yes. But as the cancer grows, you might start seeing some signs, like abnormal bleeding, especially after sex, or spotting between periods. You might also have unusual discharge or pain in the pelvic area or your back.
And in more advanced stages, there can be even more serious symptoms like blood in the urine, those fistulas you mentioned, or even swelling in the legs.
Right. But it's important to remember that those symptoms can be caused by other things too. So if you experience anything like that, don't panic, but definitely see your doctor to get it checked out.
Absolutely. Early detection is key. So let's talk about treatment options. What are some of the ways cervical cancer is treated?
Well, it depends on a lot of factors, like the stage of the cancer, overall health, and personal preferences. Like, if someone wants to preserve their fertility, that's a big consideration.
Right, that's a huge factor for many people.
So for CIN, those precancerous lesions or very early stage cancers, they might do cryotherapy, which is basically freezing the abnormal tissue, or LEEP, or laser ablation, to destroy those cells.
And for more invasive cancers, like stage I or II,
Surgery is often the primary approach. That might be a hysterectomy, where they remove the uterus and cervix. Or if someone wants to keep their uterus, there's a procedure called trachelectomy, where they just remove the cervix.
so options depending on the situation and the individual's goals,
Exactly. And for more advanced cancers, they often use a combination of treatments.
like chemoradiation.
Yeah, chemoradiation. That's where they use radiation therapy, both external beam and internal, plus chemotherapy drugs to enhance the effects.
And what about recurrent or metastatic cancer, where it's come back or spread to other parts of the body?
In those tough cases, they usually use systemic chemotherapy, which travels throughout the body to attack cancer cells. And there's also immunotherapy, which uses the body's own immune system to fight the cancer. They might use a drug called pembrolizumab for that. And of course, clinical trials are always an option, offering access to the newest and most promising treatments.
And I know you mentioned some more radical surgeries for very advanced cases.
Yeah, in some really difficult situations, they might do a radical hysterectomy. That's a more extensive surgery where they remove more tissue around the uterus and cervix. And in really extreme cases, as a last resort, they might consider a pelvic exenteration, which is a very major surgery where they remove all the organs in the pelvis.
Wow, that sounds intense. It really highlights how important early detection is.
Absolutely. The earlier you catch it, the better the chances of successful treatment with less invasive procedures.
And that's where healthcare providers play a vital role.
Totally. Especially for future family nurse practitioners, they're going to be on the front lines of this.
So what are some key things that FNPs need to keep in mind when it comes to cervical cancer?
Well, first and foremost, patient education. They need to make sure their patients understand HPV, the vaccine, the importance of screening, all of that. And it's not just about giving information, it's about encouraging those preventative measures, making sure people get vaccinated and screened regularly.
Right, it's about being an advocate for their patient's health.
Exactly. And they need to be aware of any barriers to screening, like lack of insurance or cultural stigma, and work to overcome those barriers. There are programs like at NBCCEDP, the National Breast and Cervical Cancer Early Detection Program, that can help provide screening for those who are uninsured or underinsured.
So it's about knowing the resources and connecting people with them.
Exactly. And when someone gets an abnormal result, it's crucial to follow up promptly, explain the next steps clearly, and guide them through the process. And, all of this needs to be done with sensitivity and a trauma-informed approach, especially when dealing with pelvic exams and those kinds of procedures.
It's about creating a safe and supportive environment for patients.
Absolutely. And it's really concerning that so many cervical cancer cases happen in women who haven't had regular screening.
It speaks to those barriers we were talking about.
Hmm.
Lack of insurance, immigration status, fear, stigma.
Yeah, all of those things can prevent people from getting the care they need. And it's something we need to work on as a society to ensure everyone has access to those life-saving preventative measures.
Absolutely.
Yeah.
And one final point that's really important to emphasize, even if you've been vaccinated against HPV, you still need regular screening.
Right, because the vaccine doesn't protect against every single HPV type, so there's still a chance you could get infected with one that's not covered.
So regular pap smears and HPV tests are still essential, even for those who are vaccinated.
Absolutely. It's about being proactive and staying on top of your health.
So to wrap up our deep dive today, what's the big takeaway message about cervical cancer?
The main thing is this. Cervical cancer is largely preventable. We have the knowledge, we have the tools. It's all about education, early detection through screening, and equitable access to care.
It's a powerful example of how we can make a real difference in public health when we prioritize prevention and ensure everyone has the resources they need to stay healthy.
Exactly. And it makes you wonder what other health issues that seem complex might actually have pretty straightforward preventative measures if we just understood them better. It's something to think about.
It really is. It's about empowering ourselves with knowledge and taking those steps to protect our health.